Hello, I'm Dr. Ken Landa. Thanks for watching. Let's talk about buprenorphine, with or without naloxone. That means Subutex or Suboxone, a treatment approved in 2002 for opioid addiction. Opioid addiction, obviously very common. These drugs used for detoxification and for maintenance of patients off of the drugs. They're available as tablets or film strips to be placed either under the tongue or on the cheek. We know that a significant number of people are addicted to the opioids, estimated around 2.5 million in the United States right now, about 500,000 people addicted to heroin, with the number rising. These drugs, the buprenorphine, as Suboxone or Subutex, available generically, of course, these drugs are more popular than Viagra and Adderall. They consistently make it into the top 20 prescribed medicines here in the United States. The buprenorphine itself is very sticky. It gets onto the receptor, the opioid receptor in the brain, and it knocks off other drugs. So if you take buprenorphine and heroin at the same time, you're not going to get the effect of heroin, because the buprenorphine is going to get there. And not only is it going to get there and be sticky, it's going to be tightly adherent to the receptor. It's not going to be able to come off for a significant period of time. And that means you're not going to get the rush of any other narcotic or any other opioid you happen to use. Now, it reaches a plateau effect, and as a result, it seems that it's much less likely to cause overdose, and it's much less deadly than a variety of the other opioids. We now replace the dangerous drugs with injection, with these simple tablets. And as a result, there's less HIV, fewer cases of hepatitis B, hepatitis C, fewer abscesses or embolism or sepsis. The medicine is relatively easy to use, and now they're even making it easier. There's a 1-month implant, soon to be a 6-month implant. The traditional medicine dissolves either under the tongue or on the cheek. You don't eat or drink for about 30 minutes before the application. Certainly stay away from tobacco products during that time period, because they'll alter the absorption of the buprenorphine. You rinse the mouth. You put the appropriate dose either under the tongue or on the cheek. You hold it there for about 5 seconds. One of the applications, or sometimes people need 2, a higher dose obviously. You let the medicine alone. It dissolves in about 5 minutes. So we can either use the buprenorphine with the naloxone. That's really the preferred treatment, because it's much less likely to be abused than the naloxone absence in just the plain Subutex. If you have the Subutex by itself, well, you could crush it and you could use it intravenously, but you can't do that with the component containing the naloxone, because if you do, the naloxone is instantly activated and it will cause withdrawal. Now, the DEA says the amount of naloxone in the Suboxone isn't really all that significant. Say you get about a half hour of uncomfortableness. The FDA, on the other hand, says no, we really need to use the ratio 4-to-1, 4 parts of buprenorphine, 1 part naloxone, in order to make it safe. Therapy is considered in 4 parts. There's the induction, stabilization, maintenance, and of course, ultimately tapering. All of this in combination with education and social counseling. You wait until the opioid withdrawal symptoms first begin. That's when the therapy is administered. Typically, it should be under the care of a healthcare practitioner, under direct supervision, but oftentimes is not nowadays that we're more comfortable with using the medicine. The transition period during induction takes about 3 to 7 days. You wait for withdrawal that occurs about 12 to 24 hours after a short-acting opioid, maybe 24 to 48 hours after a long-acting opioid. Tend to begin with Suboxone, especially if people are using the short-acting opioids. A typical starting dose might be 4 milligrams of buprenorphine, 1 milligram of naloxone. And those people who are taking the long-acting opioids, then oftentimes we might begin with Subutex, or it's generic. The Subutex actually not marketed anymore, except as a generic drug. Average dose going to be about 8 milligrams. Well, after the first dose, patients observe for a little while. If there's no withdrawal, no excessive sedation, hey, maybe that's the correct dose. If the person's having some withdrawal symptoms that continue, double the dose. follow them again. If they seem to do okay, then have them come back on the second day. They're doing well, same dose. If they're still having some withdrawal symptoms, increase the dose slightly. If you have to increase the dose too much, maybe that the symptoms are not from opioid withdrawal. Maybe there are other psychiatric issues, and maybe the person needs to see a counselor or a psychiatrist. Stabilization occurs during the first month or two when the appropriate dose is maintained. There's decreased craving. We minimize the side effects. Oftentimes, if the person has to use a dose of, say, 16 milligram buprenorphine and 4 milligrams naloxone, maybe the drug can be taken every other day instead of every day. Patients are followed with urine testing, make sure they're doing okay as far as social functioning is concerned. No refills during the first few months until both doctor and patient are comfortable with the relationship. Then the maintenance can be indefinite. Originally, it was thought that there only should be a short period of maintenance and then people should be tapered. Now it's thought that people can be maintained on the drug for long periods of time. Originally, the tapering was thought to best be done after 7 to 28 days, but the incidence of relapse was over 90%. Now it's accepted that long-term therapy is necessary. One study looking at people who had been successfully or who had been off the therapy for about 500 days, about 25% of them relapsed. So there's some period of time after which people seem to tolerate not being on any of these drugs. If you come off the drug too soon, well, it's a narcotic, it's an opioid, so you're going to have the standard kind of withdrawal symptoms. Not as bad as with the heroin or not as bad as with the oxycodone, perhaps, but still you have the nausea, vomiting, abdominal cramps, and diarrhea, and fatigue, and you have muscle spasms and goosebumps and a runny nose and yawning and dilated pupils. Now, how do people go into remission? Well, if we follow people long enough, most of the people who use opioids, if they live and don't kill themselves because of some other intercurrent condition, most of the people are going to do quite well. About half of the people are going to achieve success with their opioid use disorder without doing anything. They don't have to go through any formal program. They don't have to use either methadone or buprenorphine, and they seem to do well. Other people need a crutch of some sort. Maybe it's going to be the 12-step program like Narcotics Anonymous. Maybe they find a new passion, new friendships, new relationships. Maybe they find some other method to use their energy. Maybe they abuse other kind of drugs. But a significant number of people going to gravitate toward either methadone or buprenorphine. Is there a difference between the two? Well, certainly there's a difference in the way they're administered. The methadone, you have to go to the clinic every day. The buprenorphine, you get a prescription, use at your convenience at home. A lot of people don't like to go to the methadone clinics, but actually, both of the substances seem to work equally well. They have the same numbers of side effects. Maybe buprenorphine a little safer, less respiratory depression, less likely to have withdrawal from that. There's significant competition between the different mechanisms of rehabilitation. So the traditional rehabilitation centers and Narcotics Anonymous and the methadone clinics, the people promoting abstinence and the buprenorphine clinics, they all tend to fight a little bit with each other. Now, if we talk about the buprenorphine without the naloxone, buprenorphine without naloxone can be used as an addictive drug. It can be used either sublingually like it's supposed to, but people can crush it up and use it as an injection. Gained popularity as a heroin substitute, now frequently used especially in India and in France and in Iceland and in Scotland. Well, they don't sell the brand name anymore, but you can easily get the generic form, and a lot of people are prescribed the generic form in excess by the physician, and then they use the sale of the extra medicine to get money to come back to the clinic, or they buy opioids and benzodiazepines or other drugs. Actually, the buprenorphine is more expensive than heroin. Well, if you have a prescription of the Suboxone, or its generic equivalent, that's really the preferred drug, because if you crush it or do something to it and then snort it or inject it, the naloxone component is activated, and it's activated instantly. It kicks off the opioids from their receptor, and then you go into withdrawal. That's why it's popular with the doctors, maybe the Subutex, more popular with the addicts. Well, this drug frequently abused. Actually, the film strips are frequently added to magazine covers or put inside magazines taken into the prison. So it's called prison morphine or prison opium or prison heroin. Actually, in one jail in Kentucky, they surveyed 50 inmates and they found that there were levels of buprenorphine in 21 of them. Well, there's a lot of abuse going on. We know that the abuse has increased fivefold from the early 2000s. About 21,000 people go to the emergency rooms each year because of abuse, especially overdose, because children frequently get access to the medicine. And when children get access to the medicine, they overdose. There have been about 2,000, 2,500 cases every year of children overdosing on the medicine. They get accidental exposure. About 600 of these children admitted to the hospital. About 4 of them are going to die. Well, this is a natural product of an opium poppy, and it was brought out by a partnership of a private company in Britain with the British government and the United States government, all putting money into the research and development of the product. But there's a problem. We haven't been really great about treating substance abuse. So in the 1860s, people were addicted to morphine and opium. So then it was thought that cocaine would be a very good substitute. So then we had too many people addicted to cocaine. Then heroin came out, and then people were addicted to heroin. In fact, it was marketed by Bayer Pharmaceuticals, manufacturers of Alka-Seltzer and aspirin. Well, they manufactured it and sold it over the counter for coughs and aches. It was just an elixir used for all sorts of purposes. Well, then the government said, hey, none of these maintenance therapies are allowed. We're going to get rid of all of the drugs. And that's what happened with the Harrison Narcotics Act. Then in 1965, in an article in the Journal of the American Medical Association, they found success with methadone. So then they had to change the laws to allow maintenance therapy with the opioids. They did that in the early 70s. And then in the mid-1980s, they found naloxone. Naloxone was very good for treatment of opioid dependence. And then in the early 2000s, they found the buprenorphine. And the buprenorphine was licensed, as I said, in 2002. Originally, doctors had to be licensed, and then you could only treat 30 patients, later 100 patients, later 270 patients per doctor. Supposedly, you had to go and get special licensing from the government. It took 8 hours of training, special license. You had to attest that you'd make a referral to a counselor, give patients some education. But unfortunately, the doctors who were involved in the clinics had a much higher incidence, a much higher rate of problems with state medical boards, about a 10-fold increase. Doctors were frequently former addicts, or they were convicted of Medicaid fraud or had some other kind of problem, even traded sex for drugs. Well, the generics came out, and there was a big fight with the company that originally marketed the drug. They said we were going to get rid of the tablets. We're only going to have the film strip available because less likely to cause problems. Well, the government said, okay, do whatever you want, but we're going to approve the generic form. Well, what do we know about the metabolism of the drug? It actually is very slow in its onset of action. It takes about 90 minutes to peak, but the half-life is about 37 hours, about a day and a half, anywhere between about 24 hours and 60 hours, as opposed to if it's injected intravenously, its half-life is only about 3 hours. People seem to not have any effect if they swallow the drug. It has to be absorbed through the mucous membranes of the mouth or the cheek. It's excreted principally in the feces. A little bit goes out in the urine. It's metabolized in the liver. And if you have a liver problem, some kind of liver disease, chronic liver disease of moderate severity, well, that's going to impact on the metabolism of the naloxone more than the buprenorphine. And as a result, if the naloxone builds up, you're more likely to have problems with withdrawal. Well, it's not safe for pregnant women, but neither are the opioids in general. There's the possibility of low birth weight or prematurity. There's a problem with the newborns of a withdrawal syndrome. Still not recommended for breastfeeding. Of course, side effects are the same as with any opioid, with the nausea and the vomiting and the drowsiness, dizziness, memory loss, cognitive problems, dry mouth, small pupils, sexual problems, problems that range from decrease in libido to erectile dysfunction to infertility and hypogonadism, interferes with metabolism of other drugs, and other drugs can interfere with the metabolism of buprenorphine. Have to be a little bit careful. The MAO inhibitors, better not take them together, otherwise you have an increased risk of something known as the Serotonin Syndrome. The buprenorphine works on the opioid receptor in the brain. It sits on it, it partially activates it, but it doesn't fully activate it. And that's the benefit of the drug. It also works on a variety of other non-traditional sites within the brain. Overall, if we look at the naloxone component, what it does is it does not allow the narcotics or the opioids to activate the opioid receptor. The naloxone goes right to the opioid receptor, sits on it, doesn't activate it, and prevents any of the opioids that you might subsequently take from causing you any benefit or whatever reason you're taking the drug for. Well, the cost of the drugs, actually these drugs are pretty doggone expensive. If you get the combination, the Suboxone, the combination of the buprenorphine and the naloxone, 1 month of therapy is going to be about $250. If you get the tablet, if you get the film strip, it's going to be about $300. So overall, you know now about the problem we have with opioid addiction. And one of the answers, one of the solutions, is buprenorphine, with or without naloxone. But it's only part of the story. It's kind of like obesity. It's very easy to become overweight or obese, but once you're there, what's the likelihood of getting better? It's a struggle. Thanks for watching. I'm Dr. Ken Landau.